Thank you so much to those of you who have been able to stay, and I'm excited because Sam is one of my favorite people in the whole world. And I have to say that because she's a client. But Samantha is the CEO of the Illinois Association of Medicaid Health Plans. You can see her bio up on the screen and in your slides. Extremely accomplished, extremely knowledgeable, and I think we're really fortunate to have her come and share her wisdom with us today. And so I thought what we do is just have Sam do a little bit of a bio and sort of overview of IMHIP, which we affectionately call the association, and sort of what the MCOs really want to see out of the next kind of couple of years in managed care, and then we'll definitely open it up for questions.
Great, thank you, especially for that very kind introduction. And thank you all for being here, for taking a lot of time out of your busy schedules to sort of understand the ins and outs and complexities that are our Illinois Medicaid program and Illinois Medicaid Managed Care specifically. We really could not do this without you. So a bit of my background and sort of why I'm in this role is prior to my 6.5 years leading IMHIP, I was at legislative staff, and I had both healthcare, Medicaid, and human services, and really saw the struggles and opportunities that the Illinois Medicaid program sort of presents, especially for providers and for members, and how so often members were falling through the cracks, and so often our structure of a program was driven not by what made the most sense clinically, not by the providers who were really providing the care day in, day out, but sort of by who had the most political influence. And I think you see that in our rate structure and how we have structured the entire Medicaid program in Illinois. And my role and the role of managed care is really to align the financial for the state to align the financial incentives with sort of a strong public policy approach that better serves the members, that better serves those community-based providers that for so long our system is really ignoring, to be perfectly honest. So that's how I came to this. That's sort of like my background, and my vision is really to ensure that the plans have incentives to really partner with all of you, because you guys are the boots on the ground, and you guys are going to change the Medicaid program more than our institutional providers ever could. And so that's sort of my passion, my drive, but also that of really a lot of the health plans. So Illinois Medicaid, as you heard earlier today, we were really late to the game on Medicaid managed care and transitioning. We transitioned rapidly. It has been, really just 5-6 years of sort of a more robust managed care program. And I include in that ICP in the collar counties when it was really just 40,000 members. And so when you think of that today of over 2 million members in Medicaid managed care, from 40,000 5 years ago, that's been just a rapid change in conjunction with a ton of change on just sort of the Medicaid in general on the provider side. So you guys have really been, you've had a fun experience, I'm sure. There have been a lot of challenges, a lot of opportunities for improvement, and I don't think that's lost on anybody, including myself or any of the CEOs, as we recognize it's not only just the health plans that are really going through a lot of transition in a short period of time, but it's all of you as well. And so we know that. And so I know that at times it can feel as though we don't understand your frustration, or that we don't have empathy, but we absolutely do, because I often joke that we're dealing with the same state policies and the same state government that you are. We don't have a special, state agency or a special payment cycle or anything else. We're dealing with the same structural challenges that exist in Illinois. So that being said, we at the association, and especially under the Pritzker administration, I think have made a lot of strides in improving provider relations and understanding of our side, as well as I think then trying to go out and educate providers. And the bulk of that really comes through with the IMHIP Comprehensive Billing Guide. If you're not familiar with it, I know that you guys went through it today, but I cannot stress how helpful and resourceful it is, especially for all of you. But then when there inevitably is turnover at your organizations, or you're growing and you hire somebody new, it's a really helpful resource. I am not a billing expert, but I can understand it. And I can find answers for providers, which means it's written at an accessible level if I am capable of comprehending it. So prior to this billing guide, there really was not an accessible, understandable resource that explained HFS's instructions, which are separate from commercial instructions, separate from Medicare, really unique, actually even separate from the state fee-for-service program, where there was anything documented, where HFS looked at it and they said, yes, this is right, that's wrong, and it was sort of, there wasn't anything like that. And because of that, the plans were guessing at HFS policy and the providers were guessing. And the likelihood that all 6, 8, 12, 20 plans at one point were guessing the same way, very unlikely. And we also, for the longest time, I'm sure all of you remember being told, it's the exact same as fee-for-service, just bill the same way, and then you'd bill the same way and you'd get a denial. That's because it wasn't the same. It's not all the same. And we knew that. We felt that because we would then submit the encounter and the encounter would get rejected. And so we fully understood that it wasn't the same, but we didn't have sort of the resources at the department to sit down with us to walk through claim by claim and say, oh, this is what's going on. There's this edit that was put into place in our Cobalt system 20 years ago, and we're not really sure why, but we don't know how to turn it off. So this is what you need to do to get around it. And that was what we needed. I mean, we needed that level of detail, and we needed somebody to look at it instead of saying it's the same as fee-for-service. Because it's not. It's a separate system. It's all programmed with Cobalt. What a lot of providers don't know, did you guys talk about encounters?
Just very peripherally, but.
So we have encounters, they're sort of separate from your encounters, but we send what I like to think of, again, I'm not a billing person, as a receipt. We send a receipt of every claim we process to the state. That receipt is officially called an encounter, but I find that confusing because encounter rates and encounter payments, so I call them receipts. And so we send those receipts to HFS. I believe we send them weekly, but every quarter there is a true up. And when that happens, we have to have 96% of the claims we paid, the receipts have to make it through the HFS Cobalt system. Or plans can be sanctioned. They can have their auto assignment turned off. There are a lot of negative repercussions for not meeting that threshold. And so what that has done is it's made all of the health plans be really stringent on making sure every claim they pay has every T crossed, every I dotted, and meets these really specific HFS requirements, even if they would have historically paid that claim, even if they would have paid it on the commercial side, even if it doesn't look exactly as it would for fee-for-service, if it won't make it through the encounter system, they will be negatively impacted. And anytime a plan receives a sanction in a state, even if it's $100, it doesn't matter. Any fine, they have to report that fine on every future RFP across the country. So it's not only like the financial impact here that is negative, but it is also then you're reporting that when you're competing for business elsewhere in the country. So it is not like a small deal to the plans. It is significant. And so that is why, and that started a few years ago. So if you felt like a few years ago, all of a sudden, billing requirements and sort of there were more very specific denials, or you sort of started to struggle, that's really why, from my perspective. So that's sort of our background, where we've gotten, and so now I think what we're trying to do is first have that really solid understanding of these are our billing requirements. Now that we have HFS really working with us, and we've got that all documented. We want that firm foundation, and then we want to move towards how can we work together to improve above sort of just that base, processing claims, fee-for-service approach. There's been a lot of communication about we want more value-based contracting, we want more innovation, we want more investment within the community, and we could not agree more. But health plans sort of innovate a little differently than the state of Illinois, and that is we like a very firm foundation and a really firm grasp of the data before we start going into value-based contracting, innovation, risk-based contracting. And the reason for that is we need you to be successful. We need you as providers to be strong within the communities that you serve because our members rely on you. And so we won't enter into a risk-based contract where we think the risk is too great for you as a provider, which sounds sort of silly because you think, well, wouldn't you as a health plan benefit? But we won't if you are not there. We need your doors open. We need you to trust us. We need you to be able to serve the most vulnerable people in the state. And so that is why, as I like to think of it as an Etch-a-Sketch. So each time this Medicaid program has been shaken up, it's further delayed really robust innovation, because if the foundation's not solid, we're not comfortable innovating. So we're really getting to that point where we feel much more comfortable with individual plans and individual providers, and I think you're going to really start seeing that innovation in the next few years and sort of those conversations. The state is also starting to incentivize plans further for innovation, and so I think you'll really start to see that pick up as well. And then, of course, there are integrated health homes, which will further that as well. But I think we're not looking just at integrated health homes for innovation, because those are really robust. But we also recognize that there are smaller ways to innovate. There are smaller ways to improve quality and access to Medicaid members. It does not need to be a complete redesign. Not that complete redesigns are not also beneficial, but we also believe in incremental improvement as well. Am I missing any of sort of the big items before you ask me questions?
Do you want to just, and we talked about it at the very beginning, but we've got a lot of merger and acquisition and all that kind of stuff. And I did show, who's going with who and all the rest of it, but you may have a little more insight on, it's still a little cloudy. How should providers operate until there's a little more clarity?
So for now, we did just hear, so the Next Level Molina merger is not going to close, we don't think, until around the end of this month, which is February. But everything will stay the same, we believe, until second quarter of this year, so 4/1. That is tentative today. So essentially nothing is changing right now. Once there is change, there'll be robust communication from Molina and Next Level about what the changes are, who do you contact. All of that is still in flux, but we do expect communication coming end of this month and then throughout March to prepare everybody. But today, nothing has changed. They are two complete separate entities. As you know, the Aetna Illini Care Meridian Centene merger, those have closed. Today, if you are for Illini Care, which is now owned by Aetna CVS or CVS Aetna, nothing has changed today. Continue to bill on the same platform, continue to call those provider reps. We do expect slowly they'll be communicating some transitions, including moving over from the Centene platform to the CVS platform. But again, they don't want to do this sort of overnight. They cannot, and they know from a provider perspective it would be very disruptive. So they're going to do it slowly, and they'll do it with a lot of communication to the provider. So until you're told otherwise, continue to do what you've been doing. The same is true for Meridian. So while Meridian is now owned by Centene, all the Meridian claims are still on the Meridian platform. Continue to bill Meridian. Nothing has changed. Centene still owns two other products that are worth mentioning, which is the Illini Care MMAI product, so your dual eligible Illini Care, that is still Centene, do nothing different. Then there is Youth Care, so our former Youth in Care, and then our current Youth in Care, which will go live in April. That is, Youth Care is the Centene format, the Centene platform. It is not technically Meridian. It is a unique network. It is a unique everything. And bill them separate following your contract. But again, it's going to look very similar to billing Centene today.
Great. So I think what we'll do is we'll open it up for questions. Centene, oh my Lord, it has been a long day. Sam knows the plans intimately. She's been in this space a long time. So if you have questions, we do have one, Sam, about residential treatment. And I think there was a woman, there you go. Do you want to ask your question for Sam?
Well, it wasn't really a informed question. So I work for a residential treatment provider, so it would be the care issue.
Okay.
And just mention was made about facility charges for residential treatment. And I've been to a lot of statewide meetings, just different forums. I've never heard facility charges and residential treatment literally in the same sentence. I've been at my current residential over 25 years, so I'm not new to this. So that's my general, I guess that's a question.
Yeah, so what you're asking, I'm gonna first ask the question back to you. What you're asking is, who do you bill for your facility charges? Do you bill youth care or do you bill DCFS? Is that essentially the question? That's a great question. I am not familiar with the youth care contract as much because it's one plan. So I will get back to Carrie and she will send it around. Who do you bill today?
DCFS, room and board.
Room and board, because it is not a Medicaid covered service.
Correct.
I will confirm, but my understanding of the youth care contract is if it is not a Medicaid service, you continue to bill DCFS. I will confirm that this particular residential facility charge is not a Medicaid service and get back to Carrie. But based off the information you're giving me, I believe you will still bill DCFS as you are today.
And Sam, what about residential treatment for adults, like for substance use disorder residential treatment centers? So we're not talking youth and care. That is a Medicaid.
That is Medicaid.
That's where I think we were getting.
Yes, and so that is, so my understanding, and again, it depends on sort of the services you're providing, but this is a facility where children are essentially living. And it is not, they're just there for, they're not just there for BH services for 10, 15, 20 days. They're there for months. Then based off of this, that is not a Medicaid service. It's the room and board.
Right.
It is, and so that would be DCFS. I will confirm with Carrie. I will confirm with HFS and DCFS and then send that back to Carrie.
But we had a couple of adult residential treatment centers, so folks that are going in for 28-day residential. That is
a
Medicaid
benefit.
billable service.
Yes.
And so you would bill and register.
You have to register
As a facility.
As a facility. You have to have a unique NPI separate from potentially your, if you have a CMHC and you have a residential facility, you should have separate NPIs. You should,
Right.
have separate taxonomies, all that information. You'll make sure that they're both listed on the roster separately. And then you would bill and you would contract separately. I will say one thing we've run into with residential treatment is so we do not require, I believe statutorily for substance use disorder, we do not require prior auth, but there can be post auth and concurrent review. And so every once in a while we run into a provider that's not doing the post-auth, or the concurrent review, and that will result in denials. There is an appeal process in which you can demonstrate medical necessity, but it is much more cumbersome sort of after the fact. So just do make sure you're reviewing your contract and the prior auth, post-auth requirements. That is something we bump into from time to time. Not always, but it's just something we see.
Perfect. Sam is really the expert on the universal roster.
I built it.
Any questions on the universal roster?
It was a long, long process. So what I will say about the universal roster, I get a lot of questions that are already on IMHIP's FAQ. And so we have on our website an FAQ, a frequently asked question document. We have instructions on the roster, within the roster itself, because we never wanted a provider to lose the instructions. There was a lot of thought. Everything is color-coded. Some of the colors are not as pretty as others, but there's a lot of content, so we had to just start using every color. The things we get asked the most is who is a group and who is a facility.
Yeah, I think that would be helpful to run through.
If you if you do not bill on an institutional claim, you are not an institution or a facility in the mind of the health plan. And if you ever look at that facility tab, there's a reason. Like, you have to tell us the measurements of your doorways, of your hallways, the height of your toilets. Like, that is not, it's very specific on the facility tab. And so if you are not a hospital, an ambulatory surgical center, a residential treatment center, a nursing home, a SMRF, that's really
ASTC,
it.
oh, you said that. Yeah,
That's really it, like an LTAC, and a freestanding like PT/OT clinic, then don't fill out the facility tab. Don't do it. It's more work. And what I even found today is we had a provider who sent in their CMHC. They sent in their information for their CMHC location on the facility tab. The plan missed it because they weren't looking for it, and so then it created a claims issue. It's going to be cleaned up, but it's months in arrears. They have to reload, they have to reprocess everything. It's really cumbersome for the provider, because all those claims were being denied because to the plan, a CMHC they're just not a facility.
And so just to confirm, in impact, you have the FAO, member facility agency organization, and then you have group. It is a different definition
Yes.
in impact versus the universal roster. But you've got the slides and you've got the definitions within the universal roster instructions. So hopefully you won't be measuring the height of your toilets in your CMHC anytime soon.
Yes. So I think the easy rule of thumb is if you're not billing on an institutional claim in the mind of the health plan, you're not a facility.
Right.
That was sort of our guiding logic, because we don't always see we don't always receive all sort of the definitions that impact uses, and they can change, or they can fluctuate, and impact is still going through updates. So we wanted to rely on something that was a little bit more sort of firm, which is you're not going to be using an institutional claim if you're a CMHC.
Right.
Other questions?
You mentioned Centene. Do you have a website for them, or do they have a portal?
So for youth care, you mean?
Yes.
Yes, it is like youthcareillinois.com.
ILYouthcare.org.
IL Youth Care. Is it org? We'll check and confirm, but there is a youth care website. There's a youth care phone number. I will say there's been a lot of confusion. Did you guys cover the former and current youth and care rollout?
No.
So there's been a lot of confusion in the media, which is always helpful. The rollout for current youth and care is not until April 1st. And so if you have a family with a current youth in care who's saying, I haven't received my letter, nobody's contacted me, It's because they're not enrolled yet. It's not until April 1st. Former Youth in Care and special needs children went February 1st, which was 2 Saturdays ago. To put the special needs children in context, there are about 38,000 special needs children in the state. They fall into 3 categories. You receive SSI, you're labeled as disabled, or you are a DSCC child or in the core program. Of those 38,000, about 18,000 were already enrolled in health plans. They had already opted in over the past few years. So we were really just sort of taking on the other half of that population. So the networks were sort of already in place. The care coordinators are very familiar with these types of children. A lot of work had already been done with children that look like the populations that were rolled in on February 1st. Then there were the former Youth in Care. So these are families that were reunified within a year, have permanency through adoption or guardianship, or emancipated. Those children, their health needs, their benefit looks different than current Youth in Care. Their benefit looks like a regular Medicaid member, so regular kids, and then their distribution of need also looks like our regular Medicaid population. Some are absolutely special needs, some have high behavioral health needs, and some, fall into the sort of a regular kid. They get vaccines, they have a few, things here and there, but they don't all have high needs. Again, they were reunified, they emancipated, or they were adopted at a young age, right? So they could have been adopted at 1 or 2. They're now 8, but they are still considered a former Youth in Care. So that population went live again 2/1. They were allowed, and still are allowed, to switch plans. So they're not all gonna be in youth care. And so that's really important. So I believe 5,000 or so selected various plans. So make sure that when you're dealing with former Youth in Care, you are checking eligibility, and they still have 90 days from the day they're enrolled to switch to other health plans as well. So with that, their benefit's gonna look the same as their other Medicaid kids, and they are going to have, robust care coordination. Everybody, special needs and former Youth in Care, has 6 months continuity of care. So if you've been serving them under their current care plan, even if you're out of network, you'll continue to be reimbursed. If you add or that care plan changes, that's when you might need to communicate with the health plan. The other thing that's really important here, especially with special needs children, is you still have to be registered in MPAC. So a lot of physicians specifically who are serving special needs children, these kids have Medicare and Medicaid. And so if you're just registered in Medicare, if you submit a claim to a Medicaid health plan, that claim will deny, because you have to be registered in MPAC. So if you're not registered, you need to be. Or if somebody who's ordering, referring, or prescribing to these children, if they're not registered, they need to be. And this is more of an issue with special needs children than former Youth in Care, just because a lot of these kids also have the Medicare benefit. Did that cover? I know I dove in a lot more than the website, but. And we did 3 webinars on special needs children and former Youth in Care. Those will be posted to our website, which is imhip.net, so you can get that PowerPoint and all that information. We also have special contacts, escalation contacts for special needs children. So if you have an issue with billing, contracting, or care coordination for a special needs child, we have your initial contact, your initial escalation, and your secondary escalation for each health plan on our website today.
Since you went down the rabbit hole, my question is, because I work with early intervention kids, that's different than the population
Yes.
you're referring to, right?
Correct.
So are those kids in early intervention still gonna be able to get those waivers, or, not have to go through the
Yep, so early intervention is still strictly a state program. You get EI regardless of income, so it's not rolled into Medicaid. So it's separate. That does not mean there are times when there are children who are getting EI who are also Medicaid eligible, who may also get additional PT services or OT, and that's when, for those additional services, you may be bumping up against the Medicaid Managed Care Organization. But for EI, when you're billing EI, it's all separate today.
Have some kids in DSCC as well.
So DSCC children will roll in only for their Medicaid benefit. So if it's the EI benefit, it will still be separate today. There is talk about slowly moving EI in, but I don't think we need to, it's probably a year or two away. And the reason is all IT issues at the state.
Thank you.
You're welcome. And I didn't mention at the beginning, I do represent, so IMHIP represents the full industry of Medicaid health plans, which is rare from an association in the health plan market, and we only do Medicaid. And so our website has a lot of resources that I think are very helpful, one of which is we have key contacts for all of the plans for various subject areas, including provider type, including contracting, billing, and we also have escalation contacts as well. And we update that regularly, and we have a tool on our website, so if we put down Dr. Jones for Aetna, and Dr. Jones leaves Aetna, but that's still on our website, we have a tool on our website that allows you to notify us at IMHIP, and then we go to Aetna or whatever health plan, get the updated information, update our website, and then notify you as well. So that way you're not sort of guessing as to who is the right person. We do full confirmation and updates of all of our contact information on our website at least quarterly. But I think I update that like every week, it feels like. Because it's all the plans, so there's a lot of information. Any other questions?
Angela, anything that you can think of to? Sam has a podcast, Sam Says, so check that out. That is also on the website.
It is on the website. It's very exciting. We talk about Medicaid policy.
So maybe it's a nighttime podcast.
It will help you. They're all very
Unless you're a
short.
policy wonk like me, you know,
No,
but
it is, it's light. We don't get into too much billing issues. We talk more about high-level public policy.
yeah, and the other thing is I mentioned earlier that IMHIP is doing these monthly lunch and learns, and they've got a schedule laid out of different topic areas they're going to be covering. I know they did one just recently on the new single prescription drug list. They've done one on the ordering, referring, prescribing rule that changed. So again, we really would encourage you to check out the website and play around and see what you can find, because there are a lot of great resources on it.
The February one is rosters, which
Perfect
is
timing.
really
I knew it was coming up, but I didn't think it was
helpful.
that timely.
It is. And then we're repeating the roster one again this year as well, because it's just such a hot topic. And I know we've done one for ICOY in the past on the roster, because that is, I feel like, it's so critical, and it's that foundation of if your claims are going to be paid right, it all starts with that roster submission. I feel like there's always turnover, at the various providers, and sort of understanding the roster. It's very complex. Our roster is not light, and so it will be a robust education. I am leading it. To give you an idea, I've shared my slides with all of the plans who I now think use my presentation on the roster, which is helpful. It's everybody sort of the same content. But like I said, I built the roster a couple years ago, and it really was, we would have like 4 or 5 hour meetings going field by field and like deciding, do we want dashes? Do we want slashes? Is it military time? Is it not military time? All of that is standardized.
Anybody else? Well, thank you so much, Sam, for making your way over here from the Loop and the Medicaid office. And we will make sure that we keep looking at the IMHIP website for any new updates and the podcast. So thank you so much. We really appreciate it.
Thank you guys, truly, for everything you do. You guys help, you serve, 3 million people who rely on all of you guys throughout the state. So it does not go unnoticed. It truly is appreciated. So thank you.